Hello, on behalf of the Advanced Renal Education Program and the Nephrology Campus, welcome to the fifth in a series of webinars entitled Haemoincompatibility in Hemodialysis, Alleviating Inflammation and Anticoagulation. My name is Peter Stemminkel and I serve as a professor and senior lecturer at the Department of Renal Medicine at the Karolinska University Hospital, Karolinska Institute at Stockholm, Sweden. And I will be your moderator during this session. I want to say a big thank you to all the healthcare workers as you continue to provide world-class care to our patients. We have a large number of attendees today, and all lines have been muted as a courtesy. We do, however, want you to engage with us during the program. In the user panel, please feel free to submit your comments and questions anytime during the program. We have also included handouts of both the presentation and literature article which will be discussed today. If you have any additional questions after the webinar, please send us an email to the respective region seen on this slide. We are now halfway through our Hemodialysis Spotlight webinars. Over the course of these 8 webinars, we are discussing articles from the supplement recently published in the Clinical Kidney Journal, which is entitled The Duality of Dialysis Membranes, Their Attributes and Ramifications. With these webinars, we aim to help facilitate a better understanding of the functioning principles of hemodialysis with a focus on the critical role of dialysis membranes. So be sure to register to attend when you receive the announcement via email, and we will share upcoming dates later in the program. The educational program has been developed by the Medical Information and Education Office of the Fresenius Medical Care. It is intended to provide pertinent data to assist healthcare professionals in forming their own conclusions and making decisions. It is not intended to replace the judgment or experience of the attending physician or other medical professionals. The treatment prescription is the sole responsibility of the attending physician. And if you are interested in additional renal-specific educational content, I would like to invite you to browse the Advanced Renal Education Program. It's a comprehensive online platform which includes e-learning courses, review articles, a repository of previous webinars on demand, and a dedicated literature search. There are also flyers and posters available on request. To quickly access the website, you can scan this QR code here or visit directly at advancedrenaleducation.com. So it's a privilege for me now to introduce you to the panelist of today, Professor Alberto Ortiz. He's the head of the Department of Nephrology and Hypertension at the University Hospital and Research Institute's Fundación Jiménez Díaz in Madrid. He has a vast clinical experience that comprises chronic kidney disease, glomerular disease, podocyte injuries, diabetic and Fabry's kidney disease, polycystic kidney disease, peritoneal dialysis, and also vascular disease in chronic kidney disease. His many awards include the ERA EDTA Research Award of Excellence in 2020, and Dr. Ortiz has published more than 700 papers that received almost 40,000 citations, and this have resulted in an outstanding Hirsch index of 98. I would now like to turn the webinar over to Dr. Ortiz. Please.
Thank you very much, Peter. It's a pleasure for me and to be here discussing this topic that I think it's of outstanding interest to most nephrologists, especially those on the hemodialysis field. So this is the title of the talk, and I have some disclosures to make. So two kind of disclosures: the fact that this manuscript is based on a paper published in the Clinical Kidney Journal, an excellent journal. And in some parts of the presentation, external references are also included to provide further insight into the discussed issue. Furthermore, I have to disclose relationship with companies with an interest in the therapy or diagnosis of kidney disease. Okay, so this is the problem we face today. Chronic kidney disease is predicted to become the fifth global cause of death by 2040. That is in 18 years' time. And Albert Einstein told us that insanity is doing the same thing over and over again and expecting different results. So we have to change the way we practice nephrology, the way we diagnose and treat chronic kidney disease if we want to prevent this prophecy to becoming true. And we should know that worldwide, the most common form or the most common cause of death in patients with kidney failure is lack of access to kidney replacement therapy. So we should be very clear about that. But among patients that do have access to kidney replacement therapy, still the mortality is increased versus the normal population, and it's increased both for cardiovascular disease as a cause of death and also for non-cardiovascular disease. And among the non-cardiovascular causes, infection is one of the largest killers, more in patients in a resource limiting settings, but also in where resources are plentiful. In this regard, we have two visions of the problem. If we look at the relative risk of death, it's highest for cardiovascular disease and for younger patients, but it's also increased for non-cardiovascular causes. However, if we look at the absolute risk of death in the right side of the image, then the highest absolute risk of death is found in the elderly and especially for non-cardiovascular causes. So we have to address both an increased risk of cardiovascular death and an increased risk of non-cardiovascular death. And in this complex image, we have summarized the different factors that contribute to the increased risk of death. That includes comorbidities, that includes insufficient replacement of key renal functions by current kidney replacement therapies, but that also includes, because nobody is perfect, factors related to the dialysis procedure itself. And one of these we are going to discuss today, which is haemoincompatibility. Okay, just to provide some additional data on non-cardiovascular causes, chronic kidney disease was the risk factor associated with the highest COVID-19 mortality after old age. And in the vertical axis, we have the adjusted hazard ratio for COVID-19 death for different conditions. This is one represents no increase, no decreased risk. And we see that when chronic kidney disease is in the equation, hypertension is not associated with an increased risk of death, but chronic heart disease and diabetes are. However, the highest risk of COVID-19 mortality is found in dialysis patients, and it's even higher than in patients with transplantation who are treated with immunosuppressive drugs. So part of this has to do with chronic kidney disease, as patients with chronic kidney disease stages G4 and G5 are already at increased risk, but maybe also dialysis-related factors can contribute to these findings. Okay, and focusing specifically in hemodialysis patients with COVID-19, since hemodialysis patients come to the healthcare settings 3 times per week, it was possible to perform this study in which blood samples were taken throughout the course and even before developing COVID-19, and there was a clear pattern in which the plasma levels of C5a, that is a complement activated factor that provides some insight into how much complement is activated, increased prior to development of severe COVID-19, and C3a, another activated protein from the complement system, peaks during severe COVID-19. And given our current understanding of the impact of C5a and C3a on inflammation, this can be speculated or hypothesized to play a causative role in the severity of COVID-19 and of other conditions characterized by severe inflammation. And we'll come back later to these two complement factors, these proteins reflecting complement activation. So haemoincompatibility, that has to do with blood. And blood circulates in our body within vessels, arteries, veins, capillaries, and vessels are characterized by a vessel wall, which may differ for different vessels, but all vessels, independent of the size, have a common component, which is the endothelium. And endothelial cells are there to be sure that blood and its components can circulate in a physiological fashion without undue activation of protein components of the blood or blood cells. And in this regard, blood contains several enzymatic cascades, such as coagulation, such as the complement cascade, that are there to protect us from breaches in the vascular system and from invaders. And there are others, some of them are better known, and some of them are not so well characterized. In this regard, the availability of proteomics has provided an exponential increase on the amount of protein components present in blood, in red, and also in extracellular vesicles, these are very small sized vesicles derived from cells that also contain proteins. So although we will focus the discussion on the coagulation system, on the complement system, there are literally thousands of proteins in plasma and in small particles that circulate that are theoretically, it is theoretically possible that they interact with the hemodialysis systems. We do know very little about this interaction, how it takes place, and the consequences. Okay, so coagulation and complement are the two main protein cascades enzymatic cascade that we are aware of, and they interact between themselves as we will see later. The blood also contains cells, retinal cells, different types of leukocytes, platelets. Platelets may become activated when the endothelium is injured or absent, and there is also a close interrelationship between platelet activation and the coagulation and complement system. So we should look at this as a whole. Whenever we have evidence of activation of one of these systems, coagulation, complement, or platelets, we are sure that the other two are also activated, although we may not measure them or may not be aware of the consequences. And as I said before, these are protective systems. They are there to protect us from breaches in the vessels that would lead to hemorrhage or to aggression. And we can see here when the vessel wall is breached, a thrombus is made that is composed of fibrin derived from the coagulation system. Platelets are also includes other blood cells, and this is designed to prevent us from bleeding to death. But whenever there is injury to endothelium, this thrombi may occur inside the vessels and give rise to disease. That's why antiplatelet agents, anticoagulation agents are used as therapies. And also, the complement activation has an impact. It may cause disease. There are very well characterized syndromes resulting from unchecked complement activation, such as hemolytic uremic syndrome. But I think in the dialysis setting, we are not so much aware of whether, how, and what are the consequences of complement activation. So out of sight, out of mind. We don't think complement in day-to-day dialysis care as we do think coagulation thrombosis. Okay, so we have a summary here of what the endothelium looks like in its role in preventing the activation of coagulation cascades, in preventing platelet activation and activation of the innate immune system represented in these cartoons by the complement system. So the endothelial cells express multiple proteins in the surface whose role is to prevent activation of these cascades. For example, it expresses heparin, that is an anticoagulation factor. It expresses also thrombomodulin, shown there as TM, which prevents thrombin and coagulation activation. It also expresses factors such as nitric oxide or prostacyclin that prevent platelet activation. And some of these very same proteins, such as thrombomodulin, shown in this right-hand cartoon in blue, also prevent complement activation by binding glycosaminoglycans and recruiting factors such as complement factor I that prevent unchecked complement activation. In this slide, we also see these key factors that we have mentioned before, C3A, C5A, that are produced in the course of complement activation and may themselves recruit further inflammation, in addition to the very well-known membrane attack complex, C3BBB, that generates holes inside cells. Okay, so whenever a patient is in a dialysis session, blood comes out, circulates inside extracorporeal tubing and inside dialysis membranes, and these do not have endothelium. So they are not protected. These surfaces do not actively prevent activation of the coagulation of complement systems. And this is the root cause of blood incompatibility, haemoincompatibility, which are defined as adverse interactions between blood and components of the extracorporeal circuit, and they are the consequence of repeated contact of flowing blood with a variety of foreign surfaces. So not only the dialyzer, but also the tubing associated to the extracorporeal circuit, with air and with different geometrical conduits during every hemodialysis session. And after exposing the blood to these bioincompatible systems, it is then returned back to the body, where the diverse activated factors, activated coagulation proteins, activated complement proteins, are distributed throughout the body. Okay, so when the blood circulates within these extracellular circuits, some of the proteins and cells began interacting with the tubing and the dialyzer membranes, and this may have adverse consequences, as we will discuss before. So this we are shown here. This is sodium heparin, and sodium heparin is the main factor that we are using during dialysis to prevent coagulation. And in this regard, it should be considered the canary in the coal mine. So when we are thinking haemoincompatibility, as long as we have systems that require anticoagulation to prevent clotting, we can be sure that these systems are very incompatible and that the activation of other enzymatic cascade is taking place, such as complement activation and activation of other cells involved in innate immunity, such as leukocytes and platelets. Okay, so this is a diagram of the extracellular circuit. Blood comes out there, it circulates through different tubings and kinds of surfaces, and then returns back to the body. So the blood is outside the body for some time in an alien environment, just very similar, I can imagine, as astronauts in the outer space. And blood is protected from activation of this complement system, coagulation systems by heparin, the same way that astronauts are protected from the alien environment by the astronaut suits. In this regard, coming back to the topic of out of sight, out of mind, whenever coagulation gets activated, this will be quite visible. And here we have different examples of the diverse severity of coagulated fibers. And it will not only be visible, but it will eventually make dialysis impossible when the whole filter is thrombosed. So for clinicians, the clinicians very familiar with this problem of coagulation of the extracircular, the dialysis of the extracorporeal circuit, and that's why we use anticoagulant agents, mainly heparin, to treat it. But there are other consequences of the bioincompatibility, of the haemoincompatibility that we may not be so aware of. We may have unknowns. So following this defense minister of the United States that said there are known knowns, for example, we know that haemoincompatibility in the dialysis setting causes thrombosis, coagulation of the dialysers, and we need heparin to prevent it. There are also known unknowns. For example, we know complement is activated, but we don't know very much the consequences. There are also unknowns. And very recently, an unknown was described for astronauts. So when they are out there, out in space, in this alien environment, they are exposed to radiation that now, 30, 40 years later, it has been found that leads to somatic mutations and clonal hematopoiesis. So what other features of haemoincompatibility in dialysis patients are we missing now? Okay, so blood comes out of the body in the extracorporeal circuit inside the dialysers, and proteins start absorbing to the membrane surface. So there are different characteristics of the dialysis membrane: nano roughness, hydrophobicity, nanostructure, hydrophilicity, functional groups, electronegativity that facilitate the absorption of plasma proteins onto these materials, forming a secondary membrane. The absorption of proteins to the membrane surface may have different consequences. Some of them may be beneficial. On the one hand, when plasma proteins are absorbed onto the extra dialysis membrane, on the artificial surface, it like pacifies it and prevents further adverse blood material interactions. But on the other hand, protein absorption itself may result in activation of these proteins, of the protein cascades. And as I said before, these adsorbed proteins form a secondary membrane that may impede or limit the free transport of solids during hemodialysis across the membrane walls. We must understand that this is a dynamic process that progresses throughout the duration of the hemodialysis session. It is complex, changing, and competitive process of some proteins may adsorb first and then they may get modified by absorption, and they may be liberated, dissolved, and replaced by other proteins. In this regard, like 40 years ago, Broman described the Broman effect, so the Broman sequence in which large and more abundant proteins have a much stronger attractive interaction with the surface than smaller ones that predominate in the plasma bulk. However, since the Broman effect was described up to now, we are aware of thousands of proteins more that are present in the blood, and how and when and the consequence of their interaction of the membrane surface, whether they are absorbed or not, and whether absorption results in changes in the activity or biological effects of these proteins, we don't know. This is the original paper by Vroman. So he described that fibrinogen was the main constitutive deposit by plasma onto many man-made surfaces, but he also described that at that time that it was modified by absorption and was no longer identified antigenically because of this modification following absorption. And this fibrinogen is an example. This may be taking place for many other proteins, and the consequence we don't know. Okay, so what would be your reaction when your world is suddenly breached by aliens? And this is a monster alien, and this can be what takes place whenever we have a small breach in our skin, a small wound. Then there's a breach in the vessel and blood starts going out, and we need to plug the hole. Another, we have to activate the defenses, because whenever there is a breach, then microbes may enter there. And the reason for this double need for plug the hole and activate defenses is what underlies the close relationship between the coagulation and the complement systems. We have here an schematic representation of the plug the hole mission of the activation of coagulation and platelets. So we have here the dialysis surface, absorbed proteins, platelets may adhere there, leukocytes may adhere and get activated, and this leads to activation of the coagulation cascade, which is linked to the complement activation, which generates pro-inflammatory factors like C5a or C3a, which together with complement and leukocyte activation leads to, on the one hand, activation of the inflammatory response, and on the other hand, we may lead to thrombosis. We also activate the defenses whenever we have a wound, but when blood gets out of the body, it feels that the protective barrier, the vessel wall, has been breached and reacts accordingly. So complement may be activated through different pathways, through the lectin pathway, through the alternative pathway, and also through the classical pathway by immunoglobulins adsorbed to the dialysis membrane. And this results complement activation, generation of pro-inflammatory factors like C3a or C5a, memory attack complex, cell injury, and also it's linked to activation of leukocytes. Here in this slide, this is just to remind the close relationship between complement activation, which is shown here. Activated complement proteins are shown in red, and the activation of coagulation. So these three components of the coagulation cascade may also themselves lead or favor complement activation. And again, we have here C3a, which activates specific receptors in the cell surface, leading to activation of the inflammatory response, as does C5a. Okay, so why is this relevant? What's this relevant to provide some detail into these components of the complement? Because of this new concept, trained immunity, a memory for innate host defenses. So this is the dogma in any immunity: is rapid, non-specific, and has no memory. And adaptive immunity, that is T cells, lymphocytes, immunoglobulins, is more slow but is specific and has memory. So it has been the dogma for many years, but 10 years ago there was a new proposal: trained innate immunity. in which cells that are not specific to specific antigens, like natural killer cells or monocytes and macrophages, get at a state of activation, at a state of training that allows them to respond in a more intensive manner to any aggression. And I would like to emphasize here the presence of these specific monocytes that express two antigens, CD14 and CD16. Okay, so trained immunity is induced after primary infection or vaccination, confers protection against a secondary infection through mechanisms independent of T and B cells' adaptive responses, and is less specific than adaptive immunity, and thus may provide cross protection to other infections. So this is the original description 10 years ago. However, we recognize some of the components of trained immunity in our understanding of cardiovascular risk in chronic kidney disease. For example, we know that this double CD14, CD16 expressing monocytes are associated with cardiovascular risk in chronic kidney disease patients. And this may be related to trained immunity. And in fact, trained immunity manuscripts are booming as we understand more and more about the drivers and consequences. Indeed, the complement system has been shown to drive trained immunity. Not only trained immunity, but also trained immunity in an sterile form of inflammation, which is arthritis. So C3A, this complement activation factor that is produced during hemodialysis, leads to epigenetic changes in fibroblasts in such a way that following a first arthritis episode, sterile arthritis, no microbes here, if the patient has a second arthritis episode, this will be more severe and prolonged. Why? Because C3A was generated during the first one and leads to trained immunity in monocytes. Okay, so this may be taking place in hemodialysis patients. More recently, this year, 10 years later, the persons that described the original trained immunity concept recognize that it may not only be a beneficial response that prevents us from getting repeated infections, that underlines part of the vaccine effect, and that is driven by epigenetic changes and metabolic reprogramming, but it may also be triggered by pathogenic stimuli and can persist for several months up to a year. And on top of the beneficial effects, it can have unfavorable outcomes, unfavorable consequences, such as autoimmunity, transplant rejection, and exacerbated immune response in chronic inflammation, including vascular disease. Okay, and we know that during hemodialysis, leukocytes are activated. There is leukopenia in the initial half 15 minutes of dialysis, and this is associated with complement activation, generation of C3A, 3,5-FA, which may be recruiting trained immunity. It's also interesting to know that not all membranes activate complement to a similar extent, but I'm quite interested in this extreme. So you see, this is the mean, but the standard deviation is quite high. So there are patients who activate more complement than others. And indeed, these patients that activate more complement than others are the ones that are at higher risk of a cardiovascular event. So key questions are, what's the impact of comorbidities on haemoincompatibility, mainly on the haemoincompatibility that we cannot see, such as complement activation, of the environment, of the genetic background, and even the metagenome, so our interaction with gut microbes. Moreover, we know very little about the extracellular vesicles, that more and more types of extracellular vesicles are being described and how they interact with the dialyzer and impact on trained immunity. So the impact of haemoincompatibility may be both clinical. We are very well aware of dialysis coagulation and different types of dialysis reactions from transient leukopenia, pulmonary dysfunction, which was described with the earliest dialysis membranes, dialysis also related to sterilizing agents or to medications. But there is also subclinical consequences of haemoincompatibility, such as decreased dialysis efficiency and potential contribution to increase cardiovascular events and to compromised immunity. In this regard, we should aim at mitigating the effects of haemoincompatibility in hemodialysis by selecting materials and production processes for membrane manufacture that ensure optimal biocompatibility, optimal transport, but we can only do this by trial and error in the clinical settings. Additionally, attempts at surface modification have been made of polymers and biomaterials to improve biocompatibility, and eventually in the future, we may target non-coagulation pathways again to improve biocompatibility. Here are some examples of surface modifications and the potential impact on different systems: coagulation, platelets, complements, leukocytes, and inflammation. Okay, so in conclusion, during hemodialysis, the blood of patients gets out of our body in an alien environment. And this has some very obvious consequences as a coagulation of dialysis that we are very well aware of, and we can try to prevent using heparin. However, heparin is the canary in the coal mine that points out at haemoincompatibility going on. And we know pretty well that also complement is activated. We don't know so much about other cascades, enzymatic cascades that may be activated. We do know that we have to improve the biocompatibility of the different components of the dialysis system, from the surfaces to the drugs that we are using. And in the future, we may explore targeting non-coagulation pathways to further improve the biocompatibility. For example, have been made large advances in anti-complement therapies that are currently standard for some diseases and have changed the outcome of the disease. And maybe in the future, some of this knowledge may be applied to improve haemoincompatibility in the dialysis system. Thank you very much for your attention.
Thank you so much, Dr. Ortiz. This was a really excellent and interesting lecture. I learned a lot. Now you all have the possibility to post your questions, and we ask Dr. Ortiz what you want to learn about inflammation and anticoagulation, whatever questions you may have. While waiting for questions, Alberto, how do you foresee the use of additional drug interventions beyond heparin to address the bioincompatibility issues?
Okay, so we are using heparin because it generates a very acute problem that prevents dialysis, which is coagulation of the dialyzer, and that's nice. But we also know that during hemodialysis, other enzymatic cascades have been activated, such as complement, and we are really not taking any measures to prevent their activation. So companies are working in generating more biocompatible materials for dialysis, but we are not intervening clinically, in part because they are out of sight, out of mind. We don't see very direct consequences. However, as we learn more and more about trained immunity and its potential negative impact on the higher risk of dialysis patients, for example, for cardiovascular disease, so we may be thinking in intervening. And as I said before, the eculizumab, for example, has changed totally the outcome of patients with hemolytic uremic syndrome, and diverse complement targeting drugs are now undergoing clinical trials. Avacopan was recently approved for vasculitis. So I think in the short, medium term, we may learn enough about how to manipulate the complement system that it's eventually possible to provide short-term, mild complement inactivation therapies during the dialysis procedure in order to prevent complement activation. Perhaps not to all patients, but perhaps to patients that we have identified as being like uh, huge complement activators.
Okay. So you talked about trained immunity. Is it any possible ways we can train this immunity? Is this something that is possible for the future?
To manipulate, I might say, because
Yeah.
it's a concept which is pretty recent. It has been out there for 10 years, and initially the focus was on how to train the immunity in order to improve defenses against infection and in order to optimize vaccines. But quite recently, we have also become aware that trained immunity may also be playing a role in systemic inflammation, in the increased cardiovascular risk of persons with systemic inflammation, in the fact that sterile arthritis may get more severe over time. And in fact, there is a lot of interest now in learning how to regulate train immunity so as to somehow promote train immunity that defends us against infection, but limit train immunity that may increase our risk of cardiovascular disease, for example. And just before this talk, I did some PubMed searches, train immunity and hemodialysis, and there were no hits. So it's a complete empty field for research. Although we know from our prior knowledge on the risk factors for cardiovascular disease in hemodialysis patients, for example, the association of certain types of monocytes in the circulation, like CD14, CD7, CD16 expressing monocytes, they are associated with increased cardiovascular risk in hemodialysis patients. And very recently, we became aware that they are a sign of trained immunity, of the presence of trained immunity. So coupling all their knowledge on the association of some inflammation fetches with cardiovascular outcomes in hemodialysis patients, and novel knowledge on the relationship with these immunological fetches, inflammation fetches, with trained immunity. I think that we can hypothesize that there is indeed a role for trained immunity in haemoincompatibility that we should untangle and use that information to improve the compatibility of hemodialysis procedures.
Mhm. So would you dare to speculate, Alberto? Did we have this severe pandemic with the COVID that may have an effect on the immunity? What could be the overall effects of, if you see it on a global scale, on the hemocompatibility in dialysis patients after the pandemic? Do you think it has a major impact?
I think it may have had. So we saw in the slides that not all patients activate complement to the same extent. Some patients have a more intense complement activation than others. And there is also literature out there that these patients that activate complement in a more severe manner, they are at an increased risk of cardiovascular events. So the pandemic has exposed us repeatedly to systemic inflammation episodes that have been very severe for some patients. So there's a real cytokine storm that may have lasted clinically for weeks and subclinically for months. And it's likely that this chronic inflammation added, resulting from COVID-19 and added on top of the chronic inflammation of hemodialysis patients may have further impaired hemoincompatibility by providing a background higher predisposition to complement activation, to leukocyte activation. In fact,
Mm.
there is a curious phenomenon that is being studied, at least in Spain. I think it's throughout Europe, very high mortality during this summer that is not explained by COVID-19, which has not the pandemic waves during the summer, at least in Europe, have not been so severe, neither by this very exceptionally warm summer.
Mm.
So this remains unexplained, and maybe this longer time impact of severe sustained systemic inflammation resulting from one severe COVID-19 infection or repeated COVID-19 episodes may be contributing. We need
Yeah, very
studies on
possible.
that.
Yeah. So now there is a lot of interesting questions that is coming in from the audience. I will start with one of them. Do you think that IL-1 and 6 blockers could decrease inflammatory condition in chronic dialysis patients?
Well, this is a hypothetical a hypothesis that merits to be assessed. We know that IL-6 blockers um, can be effective in decreasing the severity of the cytokine storm observed, for example, during COVID-19. We also have some preliminary evidence in the lab and published that IL-6 may be one of the factors driving the decreased clotho expression during COVID-19. And we know that clotho has anti-inflammatory, anti-fibrosis, and above all, anti-aging effects, and that clotho deficiency promotes cardiovascular disease, promotes vascular calcification, promotes left ventricular hypertrophy and fibrosis. So it's one of the possibilities that may be explored. The issue is that we should design clinical trials in order to um, measure, assess the efficacy of IL-6 targeting strategies, and that's will be difficult. So I think first we have to define different degrees of haemoincompatibility. So patients that have more severe haemoincompatibility, not only because of activation of the coagulation that we may control with heparin, but also with complement activation. And these may be the candidates to a clinical trial. The
Mm.
second, we also need then, so we need some easy way that is available in a clinical setting to assess the inflammation-related biohemoincompatibility of dialysis in specific patients. Then we need to understand better what's the timeline of the relationship of this hyperactive hemoincompatibility with cardiovascular events or other events that may be the primary outcome measures of the clinical trial. After we
Mm.
have this background knowledge, then we may start designing clinical trials in which we target candidate inflammatory mediators.
Here's another question. Even among healthy blood donors, we see massive differences in the degree of complement activation on exposure to dialysis membranes.
Hmm?
Do you have any idea why some people have more angry blood and others not?
I don't know, but there is this recent paper that suggests that our genetic background has a much higher impact on our longevity than environmental exposures
Mm.
or factors like high LDL cholesterol, etc. So I think this is a research opportunity. So companies that make dialyzers, they become aware that some blood donors have angry blood and others do not. And now whole genome sequencing is becoming more and more cheaper and cheaper. There are companies that have promised to offer it for 100 euros. So I would suggest that with appropriate informed consent, the genomes of these angry blood donors are sequenced and the genome sequence be examined initially for uh, genetic variants in genes involved in inflammation, in coagulation, and eventually, in a blinded manner, in a non-biased manner, be compared with the persons who are just the opposite. So I guess we will have among blood donors angry blood, normal blood, and very pleasant blood. So I would compare the angry bladders with the pleasant bladders and check for the genetic differences. And I think we may learn quite a lot from there.
Mhm. But first, we need to define angry blood. Do you have
Yeah.
any suggestions how we should do that?
I guess the people checking the person that made the question may know how to differentiate them. So
Mhm.
the persons who are checking in a day-to-day basis the incompatibility of novel materials, they are very well aware which ones are angrier than others. But I think it's an extraordinary research opportunity
Yeah.
because they are otherwise healthy. So in the hemodialysis patients, we may also assess for these predisposing factors, but we have comorbidities, we have intercurrent infections, we have all kinds of confounders there.
Mhm. And also, I guess sex, would that be have an effect that there is a different degree of complement activation in males versus females?
Very likely. So I'm not aware because I'm not a complement expert, but there are so
Mm.
many differences between males and females that it's very likely. So this is another research need. We
Yeah.
should understand haemoincompatibility differentially in males and in females, and eventually we may reach the conclusion that it's similar. But first, we should study it independently in a set of males and in a set of females.
So nowadays there's a lot of attention and discussion about precision medicine. Do you think that there's a role for precision medicine in the bioincompatibility field?
I think so. I think we have already touched on the topic. These angry blood persons, may be eventually identified in a precision medicine approach. As I said before, genetic testing is the price, the cost is decreasing, and we are better and better able to interpret the results. So
Mm.
maybe in the future, if, for example, we think a novel approach comes by that we may not only prevent coagulation but prevent complement activation, we may not be interested in providing this novel therapy approach to every patient, just to the angry bladders, for example. So with the
Mm.
persons who have this outstanding complement activation during dialysis, and we would need some kind of precision medicine to identify them. So not all dialysis patients are similar, but we differentiate them now in a very crude manner, which is how much the dialysis get coagulated, and we may develop more sensitive approaches to differentiate people who have a human compatibility problem.
Mm. So we have now a very long questions, and maybe you can see it in the chat. I will start to read it. It's about the relationship of COVID-19 in the CKD patients. If I'm understanding it correctly, COVID-19 increases the coagulation of ESRD patients secondary to inflammation.
Mm.
Has there been a study where these patients were divided in terms of their cardiovascular comorbidities prior to the COVID infection? Also, are you recommending increasing heparinization or other anticoagulants as patients get infected with COVID while on
Uh,
hemodialysis?
yes, okay. Well, we know that thrombosis is a key complication of COVID-19, that even people with mild infections may die 1 to 2 months later from pulmonary thromboembolism. So the question is whether preemptive increased in anticoagulation during the hemodialysis session. Well, if the patient have moderate to severe COVID-19 and is hospitalized, the person will probably be on systemic heparin, so maybe it's not needed there. And regarding milder patients with milder disease, I don't know the answer, but it would be so. I think any of these clinical questions for which we don't know the answer should maybe the topic of a clinical trial, that may be a
Mm.
pragmatic clinical trial. So most of what we learn on how to treat COVID-19 came from the pragmatic clinical trials that were set up in the UK and that patients were already enrolled in March. So I think in the COVID-19 setting, pragmatic trials are very well admitted by ethics committees.
Well, I think we can conclude that this is an extremely interesting area of research. There's a lot of opportunities for research here. And our time is up. I'd like to thank you, Professor Ortiz, and also the audience for joining us today. And I would like to remind you about upcoming webinars on October 4 and then on November 15. And I would really encourage you to sign up for these webinars to learn more about dialysis membranes and how to improve the treatment for our hemodialysis patients. And with this, I'd like to thank you all for attending this interesting lecture and wish you a good evening.